they'll be able to deliver what you want. Yeah.
Okay, we are live now.
I think we are live now, sir.
Aisa? Can I share my screen?
Just
Sagar?
a second, sir.
Okay.
So I would like to welcome everybody for this IAS Academic Corner for the month of May 2023. And it's my pleasure and honor to introduce our speakers today, our very own Dr. Rajkumar Amravati sir, who is professor and head of unit of arthroscopy and sports medicine at St. John's Hospital, Bangalore. And two of his team members, Dr. Mevin Matthew and Dr. Abhay Vasdev. We'll be discussing a very interesting and important topic in the field of arthroscopy, which is actually not the arthroscopic part, that is lateral extraarticular tenodesis, LET, as we all know it. So I would like to request Dr. Rajkumar sir to throw a light on LET, when, why, and how.
Thank you, Sagar. And it's an honor that IAS picked up St. John's Medical College to host their monthly meet. And I am happy to have my colleagues along with me to share the knowledge and hope to learn from each other in this 15-20 minutes of lecture and hour-long meeting with the IAS. And thank the IAS secretaries and the president for having us on this meeting. Without wasting much time, I would like to share my screen.
Thank you, sir.
Okay. Can you see my screen?
Yes, sir. Yes, sir. We can.
Okay. And I'll just minimize this. I am audible as well.
Yes, sir. Clear and well.
So my charge today for this evening is to throw some light on, as Sagar was telling, on the lateral extraarticular tenodesis. When, why, and how to do it. So a brief introduction of this topic. We all know that when ACL is now injured or has been getting injured in the past, there is a fair amount of injury to the anterolateral structures as well. The incidence can go up from 25% to around 80% of the time. But we were not in the past able to identify these injuries, but of late, because of the advancement in science and the investigations like MRI and other clinical findings, we're able to pick up these injuries and able to manage them along with the ACL injuries, which adds value to the outcome of the patient. It is important that LET procedure is to be done, and it is found to be little superior to the ALL recursion, which always people talk about. And in our institution, we do practice both, but the major crux of our treatment for all patients with ACL injuries, primary with instabilities, are LET. There are several factors that contribute to the rotations and during flexion angles. The study done by Kittel and his group has been well known to all of us. And LET in the past was, having a kind of a black mark on its procedural value and the value addition that it gives to an ACL surgery, because it was thought to limit the range of movement or the rotations of the knee, which is not wrong, because the way it was being done in the past was not as what is practiced now. As the slides move on, I'll try to tell you how we go about doing LET. Briefly, the history about who tried to tell us all about LET was this great gentleman, Marcel Lemaire, in the year 1967, who used a strip of the iliotibial tract, which is here in this fashion. If you can see that, he used to take a strip of the iliotibial tract, pass it deep to the fibular collateral ligament, which is this one, and he used to drill a tunnel behind the lateral epicondyle in this fashion, and then bring it back again to be attached to the Gerdy's tubercle. That is what was the classical Lemaire's procedure described in the year 1967. But you can note that the fixation of this LET procedure was done in a knee flexion of 30 degrees, as well as the limb held in external rotation. As a result of which, more of the people or the people in the field of arthroscopy thought that they will limit the rotations, especially the internal rotation, as well as they will cause some reduction in the joint space and set in an early arthritis in the lateral compartment of the knee. So these are some factors that were argued upon when this procedure was added to give some value to a primary ACL reconstruction with a explosive pivot shift. McIntosh also described this procedure in his own way in the year 1976, wherein he used same iliotibial tract, but he used the lateral intermuscular septum instead of a bony tunnel behind the lateral epicondyle, and passed it through an osteoperiosteal flap, which is a graft in this fashion here, and took it under the iliotibial tract, under the fibular collateral ligament, and reattached to the Gerdy's tubercle. There are various other methods also that have been described, but these are two classical methods that we always try to simulate or emulate while we're doing our procedure on the lateral side. And when we add it to an extra-articular procedures when ACL is torn. When we are fixing this LET, there needs to be 2 points of fixation, one on the femur and one on the tibia. This was extensively studied way back in the year 1983 itself. And if you can see here, Krakow in his own study described there are so many points on the tibia from 1 to 12, as well as on the femur from 1 to 9. But he chose 9 as the isometric point on the femur, which is very close to the intermuscular septum attachment behind the lateral epicondyle. And he also chose 2 points on the tibia, which is close to the Gerdy's tubercle, point number 1 and 2, to get the tibial attachment. So these are the 2 isometric points that was described by Krakow and his team, and who found that when we take into point these 2 attachments, there is an isometry between fixation points, and it will add value and strength to your reconstruction. Briefly, if we see the anatomy on the lateral side of the femur, the structures that are very closely linked are the lateral head of the gastrocnemius, which is here in this fashion, the fibular collateral ligament from the head of the fibula going up to the lateral epicondyle, the ALL, which is often debated, is very closely linked to the proximal Kaplan fibers and attaches almost close to the Gerdy's tubercle. Then we have the Kaplan fibers, which are closely attached to the posterior part of the tibia here in the lower third, as well as proximally in little upper third also. You can see the proximal and the distal Kaplan fibers, which intermingle with the iliotibial tract and then attach to the Gerdy's tubercle. So these are the soft tissue structures that we need to keep in mind while we are reconstructing the lateral side. Also, if we go further down and expose the tissues in such a fashion, you will be exposing the head of the bicep, long head of the biceps femoris, below which you will get at the level of the neck of the fibula, the common peroneal nerve. So these are all the structures that are seen on the lateral side. You should be mindful of the anatomy that is there on this side, because there are various procedures that have been described on the lateral side. One of the procedures that will add some value and improve your outcome when you're doing ACL reconstruction is the lateral extra-articular tenodesis. Why we say that the lateral extra-articular tenodesis adds value to the ACL reconstruction that we do is, if you see here this biomechanical study that Lutzen is team did in the way back in the year 2018, ACL is a central pivotal structure in this fashion. It is very difficult for it to control by itself the rotations that are there in the knee, and as a result of which the central lateral pivot has to be supplemented with the arm which is outside in this fashion, which is in the form of lateral extraarticular tenodesis, to share the load and control the rotation of the tibia in such a fashion, and then shift the forces not into the center of the joint, but to the medial femoral condyle to avoid any instability in the knee that arises. So when we have two shoulders, it is easy to carry a load of any magnitude. But when you have only one shoulder, the load becomes too much on a single shoulder to carry. So that is the principle of adding LET to the lateral extraarticular tenodesis to give value addition and to manage the load that transfers across the knee. That is one. Secondly, if you see here in this graph, which is to your right here on the screen, you can see that when we do lateral extraarticular tenodesis, which is the superficial part of the iliotibial tract, you can see that at all the flexion angles, you can see that the lateral extratenodesis is influential in controlling the rotations of the knee, whereas the deep part is influential only to a certain extent when the knee is flexed up to 30 to 40 degrees. And the rest of all the ligament like the ALL, the capsule, the ACL, the MCL, and the PMC control the rotation to a minimal amount when the knee is flexed to 30 to 40 degrees. So it is important that if we add lateral extraarticular tenodesis to share the load when ACL is done in isolation, and also to control the rotation better in all flexions of the knee. Now, there should be some indication when we choose to do LET. Classically given in the literature by Cotet et al. Are classified into primary and secondary. When we say primary, especially those who are classically described are the ACL revision scenario, when the pivot shift grade is 2 or 3, when there is a second fracture indication of saying that there is anterolateral structure injury, sporting individuals who are playing pivoting sport, and they should be level 1 athletes, and gentleman or a lady with hyperlaxity and genu-recurvatum more than 10 degrees. There are some secondary indications also when we say that there is a contralateral injury to the ACL already, and the Lachman is more than 7 millimeters. X-ray is already showing a lateral condylar notch sign or an MRI that depicts a lateral condylar notch sign, and if the individual is less than 25 years. I also would like to add how we practice in our clinical setting in our hospital is, if I get a pivot shift in the outpatient, that is an indication for me in a primary scenario for a young individual to add ACL along with lateral extraarticular tenodesis. We also will add lateral extratenodesis when there is a posterior root injury along with posterior root injury of the lateral meniscus along with the ACL. Also, if there is a ramp lesion along with the ACL injury. So these are some of the indications that we have extended our procedure while we are doing our lateral extraarticular tenodesis. When we say there are indications, there should be some contraindication wherein we don't do. When there is a posterolateral corner injury, or when there is already an established lateral compartment osteoarthrosis, these are the contraindications that have been given in the literature, and we need to keep in mind about that. Also, if there is an extensive medial side injury, we will not add an lateral extraarticular tenodesis because of overstraining or the repair that we do on the medial side. How to do LET? I will mention only briefly about how to do LET because this topic will be covered by my colleague Dr. Abhay. But I will tell you briefly how we do it in our setting. This is a modification of Lemaire and McIntosh. We choose a point which is just posterior to the lateral epicondyle on the femur, about 4 to 6 millimeters. We identify this point by various anatomical landmarks that are going to be explained by Dr. Abhay. We give a generous incision extending about 5 centimeters behind the lateral epicondyle along the line of the IT band. For demonstration purpose, this incision is made long. We harvest the IT band about 1 centimeter breadth and around 9 to 10 centimeters long IT band graft. We braid this in this fashion and then identify the point wherein which is isometric as described by various authors in the literature. And we choose a point in this fashion and drill the tunnel accordingly. While drilling, it is important for us to make sure that the tunnel on the for the ACL and the LET doesn't coalesce. So we keep visualizing it through the anteromedial portal with the scope into the femoral tunnel. And thereby we can see that when we do so, we are very safe in drilling this. Just in case there is a coalition of the tunnel, which will be explained by Dr. Abhay, how we manage those coalition and other scenarios will be explained in the subsequent lecture. But if you can see this picture here in the center, this is the most important part wherein you can see that when you're passing the graft under the FCL, it is important that the graft has a free access under the LCL to slide. Otherwise, this will bunch up at the mouth of the fibular collateral ligament, and we will not get enough excursion of the tendon to fix it at the tunnel that we drill into the femoral side. Also, the direction of drilling is important. We drill it 20-degree cephaloid and superior, so that the tunnel that is being done does not have any violation of ACL tunnel. Why to do LET? This is because of this. If you see in the literature over the past 5 years, the number of articles that have been read is around 189. And over the last 1 year, still around 50% of that are still showing their eagerness to learn more about LET, how it influences the procedures that we do around the knee or in the knee. And there is only one article by Zafagnani and his team over so many years, which has been described way back in 2008, wherein this is the only study which ticks all the boxes saying whether there was a proper randomization, any bias was there in the study, or were they influenced by the industry to do such a study, and the outcome doesn't have more limitation than not, and its clinical outcome were comparable with other results on a larger scale. So the rest of the study does have some limitations when they have published their literature or so on and so forth. But if you see in the world over, there is a great interest in the people who practice arthroscopy and ACL surgery to add LET to their procedure, so that they don't want any lapses or an inferior outcome in an LCL procedure, ACL procedure that they do. Now, if you have to do ACL, is there an age limit on whom we can do, or is there a time limit since the injury in whom a LET procedure can be done? All indications that we mentioned in the talk before are applicable to all the individuals who have ACL injury, whether it is an young adolescent or an elderly gentleman. All these individuals come into the ambit of having an extra-articular degenerative disease added to their primary ACL reconstruction, and there is no time limit since the time the ACL was injured to add an LET. So when we do an LET procedure, maybe for 6 months duration, or maybe for 5 years or 6 years down the line, since the injury is there, the value is the same, and the outcome are comparable whether we do it in the early part or in the youngsters or in the elderly gentlemen. The outcome of these procedures are comparable. Why we do LET? Most of our surgeons, youngsters who begin their career by doing ACL surgeries using soft grafts. The soft grafts that classically are used by all surgeons to begin with are the semitendinosus and the gracilis. Of late, peroneus longus is being used for people who have moved up in the ladder in the career while doing ACL surgeries. Even the central quadriceps tendon, along with the patella or the bone patella tendon bone, are the other choices of graft wherein LET is used. LET is done. When we do so, we can see that the failure of the graft or failure of the procedure when we add LET is significantly reduced. In this study, that is done, we can say that the incidence of failure of graft when ACL is done in isolation is around 11%. And when we add LET, the scale of the revision procedures or the failure in those scenarios come down to 4%. So there is a significant reduction in the amount of failure of your procedure, and that is heartening to see when we add LET to ACL reconstruction. Also, in a meta-analysis which was done over a period of 20 years, if you can see, the number of patients that were studied were around 1010. And there are various modalities of treating an extra-articular tenodesis, either the Lemaire procedure or the Arnold's procedure or any other procedure that you take has added value. And they have found that these procedures are biomechanically superior and give similar outcomes, whether it is LET or Arnold procedure or Macintosh. But having said that, it is easier to practice lateral extra-articular tenodesis described by Lemaire in a modified way. And if you can see here, the most of the surgeons who have practiced the lateral extra-articular tenodesis in the decades from 2000 to say around till now, they are favoring their procedures, all ACL procedures, to be associated or to be accompanied by lateral extra-articular tenodesis, because they see that there is a value addition when they do this for their patients, and they have found that their failure rates are decreasing when they add LET. And if done in isolation, as I told in the beginning, that the failure chances are more. There are cadaveric studies done to compare one form of doing an ACL surgery when the knee is deficient, or ACL being accompanied by other reconstruction on the lateral side or the ALL. All of those things show that there is a possibility that some amount of constraint initially will be seen when you investigate them. As the time goes by, the tendon stretches by itself, and the reduction in the joint space that you see on the lateral side will not be seen in the long period of time as the tendon stretches. Also, if we can add this analogy to the remplissage when it came into vogue, which we do for the shoulder procedures, everybody was jumping on the group of surgeons who do remplissage, saying that when you limit the movement of infraspinatus by doing a remplissage, there will be big amount of rotational deformity in the shoulder. But over a period of time, we can see that the tendon stretches, and then there is comparable results of the normal side as well as the affected side. Similarly, here when we do an LET on the lateral side, the tendon over a period of time stretches and adds value to the extra-articular procedure as well as the outcome in ACL surgeries. Similarly, in these studies, there are various forces that cross, the forces that are transferred across the graft when ACL is done or ACL is along with LET have been studied. It has been found that the load transfer across the ACL in the initial part of the surgery is well balanced by the LET that we do. And as I said in the beginning, there is a load sharing between LET and the ACL. So there is some kind of a protective phenomena in the beginning when we add LET, when the graft, that ACL that we have done is ligamentizing. So it is important to understand this kind of load sharing concept while we do LET and add it to get a good outcome for your ACL reconstructions. Does the type of fixation that you use for LET influence the outcome of your ACL procedures? Definitely not. You can choose whichever kind of fixation you want, whether it is a staple, whether it is a screw through your tunnel that you drill on the lateral side of the femur, or you use a staple or you use just a osteoperiosteal flap as initially few surgeons used to practice. I have seen them doing it in Porto, and I'm sure many of you would have been witness to Dr. Mendis's technique of doing this osteoperiosteal sleeve. Whatever technique you use, but make sure that the implant that sits on the lateral side of the femur doesn't irritate the skin much. A staple with very less amount of metal on it can cause less irritation to the skin and the soft tissues on the lateral side. A very wide staple, a big staple on the lateral side can cause some irritation, and the patient will always find that the scar around the lateral side of the knee, and he'll try to scratch his skin there and find that there is a metal or a device under his skin, which is always be in the back of his mind, and would like to bring it to your notice every time he visits your clinic in the post-op period. So make sure that you use an implant which is very feasible and comfortable with you when you practice. But yes, the type of fixation that you use to fix your lateral extraarticular tenodesis, whichever it is, does not influence how the outcome comes, but all of them will give equal results when you use it judiciously. This is the most important thing that I found out in the current literature. Do these gentlemen or the ladies or the youngsters return to sport in the required amount of time that is desired of them when we do a ACL reconstruction along with LET? We have found that there is a great amount of return to the sport, not only to the level what they are playing, but it is to the desired amount of expectation what the athlete has. But it is another component of return to sport, which is very, very important, is the fear factor that an athlete has in his mind. If that matches to how he's wanting to cope and the desire or the hunger that he has to come back to play and participate at the same level matches, then the procedure that you've done will definitely add a great amount of value and success to the career of an athlete. And this literature rightly quotes that, yes, they can return to their playing level, which is comparable to the pre-injury level without any doubt. So there should not be any iota of doubt in the gentleman or the person to use lateral extraarticular tenodesis in an elite athlete, thinking that, oh, when I use lateral extraarticular tenodesis, whether the return of sports will be less or there will be some stunted progress when we do that. That is not the case. Definitely all of them in whom the lateral extraarticular tenodesis is done do return to sport very well. Yes, osteoarthritis or the progress of osteoarthritis once the ACL injured starts in the beginning only when the ACL day 1 or the day 0 of ACL injury, the cascade for the knee for going for osteoarthrosis starts. If I have to say whether the chance of osteoarthrosis for the knee after an ACL injury decreases, I can say when you add LET, definitely that amount of lateral extraarticular tenodesis reduces, because the control of micro instability in the knee is better when we add LET. And you can see in the long run that the lateral compartment also doesn't so much of changes. But when isolation, if you do only ACL surgeries, there is a possibility that there are some amount of micro instabilities. And compared to the normal knee and compared to the person who has not undergone an LET, there will be a little higher amount of wear and tear in the knee, and the osteoarthrosis cascade that sets in at the day of injury can progress to a greater amount. This is how a pre-op X-ray will look when we do an ACL surgeries. Specifically, I have used this kind of implant to show that how close and how near an LET tunnel as well as the ACL tunnel here. This is the AP profile of the post-procedure of an ACL reconstruction with LET. That's the screw. It looks like that fashion. And this is how it will look in the lateral view where the ACL and the metal screws are there. So once your location of the landmark of the LET and the ACL tunnels are perfect, there should not be any skepticism in the mind of a surgeon to use this procedure in combination to get a better outcome of their surgeries. We are roughly at around 81 cases in our series. The detailing of this will be dealt by my another colleague, Dr. Mevin. And these are the outcomes which showed a great improvement in all the clinical scores that we use to manage these patients. And when we do such a surgery for a long period of time, we do expect some amount of complications when we do lateral extraarticular tenodesis, which is there in all our surgeries. But some surgeries, some of these complications are very specific for lateral extraarticular tenodesis, like the tunnel coalition and the failure of fixation device migration. And very importantly, some amount of nerve injuries can happen if the dissections goes haywire. It is important to know our anatomy on the lateral side. It is important to visualize how you drill your LET tunnels. It is important to handle the tissues well so that the graft doesn't fail. And also it is important to control the bleeding that is there on the lateral side, which is very, very important because the lateral circumfemoral vessels that come there are very close, and when you make a nick behind the lateral epicondyle, these kind of vessels are there lurking, and it is important for you to identify that, because once you're doing your surgeries under tourniquet, you'll not be able to see the bleeding much. But once you release a tourniquet, there are definite amount of collections and hematoma forming, and investigations like MRI or ultrasound can show the amount of collections there on the lateral side, which can add to the inferior results of your patients, or sometimes the patients keep complaining of pain, or the hematoma that is found can be a nidus for an infection that can proceed in the coming days. So it is important to recognize all these parameters and treat them accordingly whenever you come across in your clinical practice. Yes, you can see that the staple can migrate when you put in a bone where the quality of the bone is poor. So it is important to use proper devices to secure your lateral extraarticular tenodesis when you're doing along with the ACL. So the take-home message from my end, when you do an extraarticular procedure would be, arthroscopy has come a long way since Lanny Johnson described this. We were very, very focused to do this procedures mostly within the joint, but many techniques are there now for ACL, but none of them give good or consistent results if they are done in isolation. As a result of which the science has advanced, people have moved out of finding ways and means to get better outcome out of their ACL surgeries. And the answer for that is the tissues that are there on the outside of the knee, especially the ones which are there on the lateral side of the knee, which can give better outcome. And they are the key now to say that which will add value to your ACL reconstruction. And now is the time for all of us to unlearn and relearn the value of these structures that are there on the lateral side of the knee, and to improve the outcome of ACL reconstruction. With these few words and the opportunity given to me, I thank IAS and thank you so much. I welcome you for IAS Con 2024 in Bangalore, and a humble appeal from all of you to consider for us for the Vice President in the coming elections for the IAS. Thank you so much.
Thank you, Rajkumar sir, for a wonderful talk. It was an intriguing and very interesting talk. We got to learn so many things. Sir, just one burning question from my side. Is lateral extraarticular tenodesis always your pre-op decision, or should be your pre-op decision? Or intra-op, do you test it again for the pivot, or a grade 3 pivot or grade 2 pivot post your ACLR?
What we practice in our clinical setting is your decision making for adding LET for a primary ACL reconstruction should be outpatient. Because if you are not able to demonstrate patients pivot shift in the clinical setting, that is outside, any gentleman can have a pivot shift when you do it in the theater wherein patient is under anesthesia. So that should not be the criteria. The criteria should be when the patient is awake, when he is mobile, what difficulties he is having, and how much of limitations the gentleman has in doing his pivoting sport. That is what you need to consider. Apart from that, the investigations will add value. Say, suppose, as I said, whether he has a root tear, whether he has a ramp lesion, whether he has a notch sign on the MRI, all those should be taken into consideration when you plan your primary ACL along with the LET. Because in our country, it is important because the patient pays from his pocket. Yes, insurance will add some amount of financial support to the patient, but that's not all. At the end of the day, you need to do one surgery for the patient, and the patient should be happy at the end of the day, getting back to where he belongs, doing what he likes to do. We should not take a second chance, because the financial structure of a country of the middle class people is such. So we need to give what is best and do it in the pre-op clinical setting to say that, yes, this is the guy, I am going to do LET. But there will be some situation which will be very, very, you can say, options to what we are discussing. Other day we were doing a case in the theater. There is no pivot shift in the outpatient. There is no pivot shift under the anesthesia. When we go in, we are wondering whether there is ACL tear at all, because it's in the MRI. When we go in, there is an ACL, complete ACL tear, which was shown long time back. The lateral wall is empty, so we decided to do ACL reconstruction. And while we were probing on the medial and the lateral side for the meniscus, both the roots were fine. But somehow when we probed the medial meniscus, we found that the tension in medial meniscus was so much soft that it was like a cotton wool, which is very, very rare to find it like that. Generally, we don't go and see our posteromedial side, which should be a part of a routine examination in the knee. This I am giving it as an example because it happened to us last week only. There is a big ramp lesion there. Even when we probe this meniscus, it is not coming in the front, saying that the meniscus is not intact. So in such a situation, we need to add other structures suggesting that because this ramp lesion cannot happen by itself, there is some amount of pivoting that is happening on that side. And that is when MRI will be very, you can say, less sensitive to pick up these kind of ramp lesions. Expert radiologists are the ones who pick up these posteromedial contusions. And sometimes in a busy clinical practice, we'll overlook such a posteromedial contusion of the tibia. And in such scenarios, it is important for us to add LET, and that planning has to be done. And this kind of a technique should be learned by everybody. Because some tight corners you need to come out. And this is one bailout that you should have in your clinical setting.
Thank you. Thank you.
Rajkumar sir, I have one question.
Yes, Sandeep.
Sir, your experience with LET with ACL repair, like have you ever done or any indication in your practice?
I do very few ACL repairs. Yes, reconstructions I do. There are very few. There is some background noise.
Sorry, sir. Yeah. Yes.
Yeah. So while I do ACL repair, generally I look at other structures that are involved, and then I add LET. But my cases where I have done ACL repair that you are asking are very few. And one of the cases we have added LET as well. But at large, by and large, if you have to ask me, the numbers of ACL repairs that I have done in our clinical setting are very few. Yes, primary ACL reconstructions are the large number of cases that we do in our setting.
Thank you, sir.
Thank you, Sandeep.
Rajkumar sir.
Yes, sir. Naresh, sir.
Sir, what precautions you take while fixing the LET for not making it over tight?
Okay. I think this question will be answered by my colleague, Dr. Abhay.
Sir, if I may
ask me. Abhay, please.
Yeah. So, sir, in literature, it says that it should be 20 Newton. Yes. So now, So now the thing is, I don't know how to calculate 20 Newton intra-op. So what we do is we just, the moment our LET graft enters the tunnel and exits through the medial femoral condyle, we just put enough pressure so that the graft is a bit taut. So now if, how will you know that is that, there won't be any bunching of the graft, first of all. Second thing is, once you probe it with your, say a probe or something, it should not be too tightened. So now if the LET becomes too tightened, we have a lot of issues like, very tight lateral compartment, and even patellar mobility also might be hindered with this. So a basic way, a crude way, or layman way to do it is just take a probe, make sure that it is not, and whoever is holding the graft on the medial side should not just hold the graft. That's it. When you are putting the screw, just hold the graft. Don't tension it, nothing, and just see with the probe that it is, there is no gap between the bone and the graft. That's it. I don't think there is any other way to see if there are 20, we are applying 20 Newton force or not.
Okay.
Thank you.
If you have to also make sure and sleep well, your limb should be at 30 degrees of flexion and the limb should be in neutral rotation. Make sure you hold it at that. And then
Yes.
if you think you are very, very, afraid of, over tightening the compartment, you can just put a probe under the lateral extra-articular tenodesis, and that will add little laxity to your compartment. Put your probe under the graft that is going into the femoral tunnel and then tighten on the medial side. So that will give some movement or laxity in the graft. And also make sure that once you do your ACL and LET, the knee should have complete range of movement, both flexion as well as extension. There should not be any limitation of whatsoever movement in the normal range that the gentleman or the lady has. So then you can go and sleep well. Otherwise, if you see that some amount of limitation is there either in flexion or extension, there is something that is not right, should be your thought process, and you need to, I'm not saying redo everything, you can loosen it a bit and then check what is right and what is wrong. And probably you'll be able to titrate it well.
Thank you, sir.
Sir, I
Thank
have
you.
more questions, sir. If we
Sir,
have
one more question regarding the ramp lesions associated with LET or associated doing LET procedures. Do you do in all your ACL cases to check for ramp lesions while by going through a posterior portal, or only when? How do you decide?
Okay. This should be the general examination of the knee that we do in our setting, and we teach all our fellows and colleagues. Is you start from the suprapatellar pouch. You do your examination of the trochlea. You check the undersurface of the patella. You slide down the lateral surface of the femoral condyle. Check the tightness of the lateral compartment. See whether the scope is going through the area where the popliteus inserts, and look for the meniscoscapular lesions and the popliteus lesions on the lateral side. Then you come back on the medial slide, check for your ACL injuries, check for your meniscal injuries. If you don't find anything, then why the gentleman should have a pivot shift with the ACL alone or the explosiveness that he has? Your completion of a normal general examination, the knee should include going into the posterior medial compartment. It is important because that is an exercise which, kind of a tactile thing that you need to develop, because this kind of technique will be useful for you not only doing the ramp, while you're doing your PCL reconstruction, you need to see from that end and then bring your needle from the medial side to have an access to the PCL. So it will become an access. And once your brain recognizes that, okay, this is the way I'm going and doing, you will be well equipped to manage other kind of injuries, not only the ramp lesions. You will be also able to do different techniques from the posterior medial side to repair as your roots as well, which have been described in the literature.
Thank you very much, sir.
I think Dr. Sunit has some questions.
Yeah, so I think, sir, do you think that both the routes, I mean, the medial and lateral routes, are actually a contraindication for LED? Because if the medial root tear or big ramp lesion is there, then the explosive pivot will be there probably because of that meniscus. And you already said that the lateral root tear, if it is there, then probably LED is contraindicated. So does we take that?
Not contraindicated. We should do, because the lateral meniscus root, which is in the posterior, is because of pivotal injury, and it will add to the explosiveness of your pivot shift. So as a result of which, that should be stable when you are doing your ACL reconstruction. That should be repaired. And then you add your lateral extra-articular tenodesis to protect your repair and share the load while these tissues heal.
And what
In
about the
acute injuries, the lateral side injuries are very common. The medial side injuries are, especially the root tears on the medial side, are degenerative tears, not primarily traumatic tears. Primarily, they can be bucket handle tears or any kind of a flap tears or a radial tear in the long run, or you can see a ramp lesion. The medial side root tear is generally a degenerative tear. I am sure Sagar and Sandeep and Naresh will agree with me with what I am telling.
That's true.
Absolutely, sir.
Sir, one small question, sir. Sir, if you
You
are
ask big
doing
question only. Why are you asking small question? You ask big question. If I know, I'll tell. I know. Otherwise, I'll tell my colleagues are there. Please take opinion from them.
Sir, I am asking whether there is a lateral meniscus root tear. After fixing the lateral meniscus root tear, whether if the pivot is coming down, is there a need for doing LET?
There should be the need to do LET because you need to protect your repair. The only way to protect repair is, as I showed you in the biomechanical thing, load sharing. Load shedding. Load shedding is in KEB. Okay. Load sharing is in the anatomical repair that you do. So it is important to add load sharing to your repair because you don't want to see your patients coming back now and then saying that I am not very happy with the knee that you are treated, and I am finding that some amount of discomfort is there. I'm not able to get back to my playing days. All those things we need not listen. You do one surgery and you always should be happy to see a good patient in a clinic. Yes,
No, I think
they are all not there in the supernatural league, but whatever God has put in your plate, you should be able to handle it well.
Okay.
Yeah, I mean, sir, if you are considering the lateral meniscus root repair, then probably by adding the LET probably might increase the the joint reaction force a little more. So we don't want any compression force on the lateral side to add. So probably the LET might actually hinder the healing of the root of the lateral meniscus. So in that sense, do you think that
Okay, there are two periods in the literature where you say that the LET procedure was literally, banned, or you can say stopped from doing because the procedure arose out of Europe. The other continent people definitely not like the Europeans to take an upper hand in whatever procedures they do. Same thing happened with the lateral procedures also. Once
Yes, sir.
they gain popularity and the science develops, people will know that how to do an LET. The techniques have changed now, how Professor Lemaire used to do, and how the technique has been modified over a period of time to add value to your ACL reconstruction. We also know the analogy of remplissage and LET, wherein the tendon can stretch once it is fixed over a period of time. And literature has shown both biomechanically as well as in cadaver studies that the tendons do stretch and the pressure that is there on the lateral compartment is not great. Ellen Getgood and his group are doing great study in this stability studies. They are focusing on how best and these procedures can add value to your ACL reconstruction in the primary scenario. So I am sure that thought process should not cross your mind while you are adding LET to your procedures when you see a lateral meniscal injury.
Thank you very much, sir.
I agree with you, sir. Fortunately, I was there participating in a research project at Western Sydney University. When you have an intact cartilage and an intact meniscus after you have repaired with a ligament that is being reconstructed, it's actually very difficult to constrain that joint just with a soft tissue structure. Your soft tissue might break, but it's very difficult to have a constrained joint after that.
I agree with Sagar. I forgot to mention that the mirror to your problems in the medial and the lateral compartment is how the life of the cartilage is. If you see cartilage injury and if you also see a meniscal injury, it is important that that cartilage that is injured is probably because of the meniscal injury and the nature of microinstability that is there. Your cartilage reflects what the knee is facing. So that will give you an idea that yes, I need to make sure that everything is fine in the knee when I finish my procedure. So it is important to add LET to your procedure and then sleep well.
Thank you. Thank you, sir.
Thank you. Thank you so much for having me, Sagar.
Yes,
and Hajara sir, thank you so much.
Thank you, sir. So now we move on to our next presentation by Dr. Mavin Matthew on functional outcomes of LET with ACLR with PKTD analysis. Dr. Mevin.
Dr. Mevin, please unmute your audio, please.
Hello. Can you
Yes.
hear me?
Yeah.
Yes,
Can you all
yes.
hear me? Yeah. Good evening, everyone. I thank IAS and Dr. Rajkumar sir for my small case series which I have been doing. So I'll be sharing the screen right now. So can you all see the screen now?
No, Dr. Mevin, we are not able to see your screen.
Yeah. How about now?
Yes.
Yes, yes, yes.
So to begin with, I've done my post-graduation in St. John's when I joined in 2018 till 2021. And I was fortunate enough to be in the unit of Dr. Rajkumar sir. And then we started discussing about what my thesis should be and how it should go about. So first of all, it came out with the plan that we will be planning to do ACL reconstruction along with an anterolateral reconstruction. Whether it is an ALL or if it should be an LET was in a dilemma. And then we went through the literature. We took a lot of time, and then we came up saying that LET would be a good procedure rather than doing an ALL procedure, which has been advised by Sonari Quartet. So as Sir was discussing about the anatomy of the anterolateral complex, so when you see the attachment of the ALL at the femoral side, it is between the lateral gastrocnemius tubercle and your lateral epicondyle, and between the Gerdy's tubercle and your fibula head. So it is in more perpendicular orientation when it is compared to the non-anatomical procedure, that is your LET, which has been described.
Slides are not moving. Sorry to interrupt.
Yeah, I'll be moving. Then we decided
And make
that,
it in slide mode.
Slideshow.
Slideshow. Yes.
yeah. Is it okay now?
Yes, yes, it is okay now.
And we decided that since the LET procedure will give control over the knee in all the flexion angles, we decided to do LET. So I started my thesis around 2018, and we slowly started doing the procedure. So our primary objective was to assess the subjective and objective outcomes after combining ACL reconstruction with LET with Lamaze, and then to assess the rotational stability with compatible MRI compatible PKTD. So it was initially how to assess the stability, whether to get a quantitative or a qualitative and a subjective outcome. We thought we'll do everything. So we did functional outcome scores, and then we analyzed the knees which we have done with Porto-knee testing device. So the inclusion criteria of this case series, which has been done for 15 patients. Out of the 85 patients, I'm yet to follow up my other patients as well. The inclusion criteria is around patients of age between 16 to 50 years with ACL tear associated meniscal injuries. Exclusion criteria included patients with knee dislocations, any contralateral reconstructions, associated PCL injury, isolated meniscal tears, and combined knee injuries. So I have calculated the sample size, and it came up to 15, and we included all those who met the inclusion criteria. We confirmed our diagnosis clinically and radiologically with MRI. We did ACL reconstruction with modified Lamaze in all the patients. And all these patients were evaluated at 6 months, 12 months, and 24 months to see their progress in the functional scores, which included KOOS, Lissam-Tegner, and IKDC. At 24 months, we have assessed our posterior-anterior translation and the rotational stability with Porto-knee testing device. So this is the procedure we have selected, and this will be further discussed by Dr. Abe, who is my senior colleague. So coming to the Porto-knee testing device, so this is an article published by Mendes, Professor Mendes, who has said about the global rotation has high sensitivity in ACL lesions with stress MRI. So when in this article, if you go through, they will tell you how photo knee testing device has helped them to quantify the laxity in an ACL deficient knee. So then we had an idea, why don't we do the procedure and compare the post-op surgery knee, post-surgery knee with the normal knee of the same patient. And then we create a mean value and a standard deviation value. And then we compare whether the surgery knee is able to compare with the normal knee. So for the same patient. So here, if you can see the device, this is where you have your thigh support. This is where your knee is being supported, and you can keep the ankle and the tibia in neutral position with the help of the foot support, which can go further into internal rotation and external rotation. And then you can give a postero-andro translation from the posterior calf of the knee. See, all this is being connected by a pump. And then you use a body coil MRI, 3 Tesla MRI. And then for each sequencing, it took around, for 6 sequences we'll be doing, which will be normal in internal rotation, normal in external rotation. We'll give PA translation. We'll see the measurements in that, and we'll give internal rotation and external rotation for that. So around six parameters, 12 values, around and 12 values to 12 values in both the knees. Around 24 values we'll have to calculate post doing this. So it took around 30 minutes for one knee and 30 minutes for the normal knee as well. So this is the demography where almost 40% of my patients were about 30 years, and majority of them had a twisting injury, and the most common side were the right side. So when you see the results, we had improved Lisholm score from 73 to 95, and IKDC score was increased from 57 to 91% at the end of 91 at the end of 24 months, and Q score was from 65 to 92 at the end of 24 months. So all our functional scores were good. Now whether it is comparable to the quantitative scores. So this is the PKTD analysis with the healthy knee compared with the post-surgery knee. So here, since we are in the initial stages of our surgery, around only 5 patients showed around 3 parameters or 3 to 5 parameters were statistically different from the healthy knee to the post-surgery knee. But other 10 patients were almost similar when compared to the post-healthy knee. So all our coming to the discussion part. So the PKTD analysis was comparable to the knee, normal knee, except for all the these 5 parameters, where the internal rotation with lateral plateau and post-andro translation of the lateral plateau in internal rotation, post-andro translation with of the medial plateau in external rotation, and post-andro translation of the medial plateau and the lateral plateau. Only except for these 5 parameters for the 5 patients, other 10 patients had no statistical difference. That means our healthy knee is being able to, our surgery knee is comparable to our healthy knee. And they had a very good functional outcome and a clinical improvement from grade 3 to grade 0 and grade 1 pivot in all the 15 cases. So the limitation of the study, which I would say was the smaller sample size. We are actually, I'm joined back as a fellow under Dr. Rajkumar, and I'm just continuing my project to look out the outcome for other patients as well. So once we get a major data, then I think all these 5 parameters also will reduce as well. And measuring the medial and lateral plateau, there will be an inter-observable variability as well, because we had one radiologist who has helped in our study. So he was also new to the study, and maybe because of that. And then we didn't have any preoperative PKTD measurements of the injured knee. We were comparing it to the normal knee. As we all know that God has given something and we try to reconstruct something, it will not be the same as a healthy knee. However, and then while doing the scans, patients are all awake, so there will be some amount of muscle guarding as well. So this is a pre-op and the post-op X-ray where you can see the tunnels. And this is where I would want to stress on when you see the lateral plateau and you give a posterior anterior translation and you internally rotate the knee, the lateral plateau tends to come in front of the distal femur. Correct. So when you see, so that is where you assess the lateral momentum of your LET. So if you get this right to the normal knee, you could say that you have already reconstructed a knee which is anatomical or near normal to the normal knee. So when you see of the surgical knee, the lateral plateau translation in internal rotation was around 10.9 in the mean, and for the normal knee it was around 9.25. So we have, it's not a much difference where there is no statistical significantly different values here, but you could say that you have reconstructed your post-surgery knee and is comparable to the normal knee. So coming to the conclusion, you have a good functional and a clinical outcome when you do LET with your ACL reconstruction, and PKD analysis is almost comparable to the normal knee. So PKD is a dynamic MRI which can quantify the posterior and rotational laxity. So post-operative PKD analysis can assure your patients that you have given them a normal knee. And then it can be clinically utilized for any injury prevention, differential diagnostic treatment, surgical research results, and for the research purpose of your ACL reconstruction as well. Thank you.
Thank you, Dr. Mevin, for a wonderful talk. It's great to see you continue with the same project with your fellowship. Very rarely you get that opportunity.
Yeah.
I just have one query regarding the Port OKT device. We have seen that we are able to mimic the rotational effects as well as the anteroposterior effects with the Porto device in situ. But there is one more component, that is axial loading. So how do we take that into consideration? Because that is going to be one important factor when the patient starts loading their knee. So loading with a rotational and anterior force. So do you do something extra for that to mimic the axial loading patterns for the knee as well?
We don't do any axial loading patterns in the PKD because we make the patient lie supine. And moreover, I think the axial loading will affect for the injury to happen. So we were doing a study where we are comparing to the healthy knee. The healthy knee was not in axial loading. So you could say that axial loading wouldn't come in our study, where the healthy knee is also not under any axial loading. So we have met all the other parameters where only axial loading is not there. So, and being compared to the normal knee, we got almost all the values which has been there. So except for the initial stages, I think if we have a case series of another 40 cases, if I do my PKD analysis, I think that even that 5 parameters would come as obsolete. Yeah.
Yeah, rightly said. I think only the Tegnell Lasham scoring along with the Port OKT will answer this, whether the axial loading actually changes or not. But a wonderful study overall. Congratulations for the same.
Thank you.
I think because of the COVID, we were not able to get back those patients. I think this guy was doing the thesis during that period, and when the exams came very close, and that is the time when the COVID started, and we are not able to get our patients back for follow-up. So of late now we are getting in touch with them since he's come back to us. And hope in the coming days we should be able to give you some data on how the patients are doing with the LET and PKTD assessment. Having said that, where is your assessment on the medial side as well as on the lateral side in your MRI? What is your landmark to say that yes, I am measuring the correct lateral compartment and I am measuring the right medial side when you are doing your assessment both on the medial and lateral side?
Yeah, so when to name where is your medial compartment and your lateral compartment, this has also been explained by Professor Mendes in his article, where he has said that you have to take your medial compartment where there is the insertion of the medial gastrocnemius on your distal femur. So that is the slice which you have to select. And for the lateral compartment is at the origin of the peroneus longus. Okay, so that is where you have your center of the lateral compartment and the end of the medial compartment. So we specifically select those slides, and so that there is no much variation in your slide selection and your measurements.
Thank you, Dr. Mevin, for that point, because it is important for us to train our radiologists and sit with them and spend some time before we call in our patients to, for analysis, because it is half an hour for each knee, and if we are not set in doing the right measurements, then the outcome for those patients, it may be, the measurements may be itself erroneous, and the outcome may come something else. So I think training your radiologist was a good point, as well as in telling them what is the right anatomy. Thank you.
Thank you, sir. So I think we can move on to our next presentation by Dr. Abhay Vasudev on the LET technique and the ways to find the proper landmark. Dr. Abhay, please.
Can everybody see my screen?
Yes, we can.
Okay. So first of all, I would like to thank IAS and RK sir to give me this opportunity to speak on such a topic. Now, without any delay, I'll start. So this is our paper, which is going to be published soon on arthroscopy techniques. So here we have described what are the anatomical landmarks which can be used to point a specific landmark where we have to put the drill and where we have to drill the tunnel. So now let's start with the detailed how it is done by us and how we do it in our setup at St. John's. So first of all, 7 to 8 centimeters incision. It's starting just posterior to the lateral epicondyle. First thing I should tell that we should always mark the landmarks properly. So what all we do is, before arthroscopy itself, we have already marked our patella tendon, tibial tuberosity, posterior middle border. Then for your LET specifically, we mark the Gerdy's tubercle, lateral epicondyle, fibula head, and also mark the LCL and our incision, which is going to be. So the incision, when we started, I think our incisions were bigger, maybe 7 to 8 centimeters. Now the incisions have become smaller, around 5 to 6 centimeters, and you can just extend it. The next thing is we go dissect the subcutaneous fat, go to the graft. The graft length has to be minimum 10 centimeter and a width of around 1 centimeter. So this 1 centimeter is very important. Now what we do is, when we are taking the ITB graft here, so usually when we put our scale, the scale comes from here to here, it will come around 1 centimeter. But when we do the incision, the graft becomes very, very small. So it becomes very thin. So it's very important that at least 1 centimeter of graft has to be taken, so that we are drilling say a 7 mm or a 6 mm tunnel, and it should not be floating inside. Now, next is, this is our ITB graft after we clear the undersurface fat from the graft, and also we just release the vastus lateralis attachments. Now we use this is a Cironix whip stitch which we use. This is number 2 multifilament loop sutures. We have very good experience with this suture. The graft comes out very nice, and it goes into the tunnel very nicely. So this is how it is whip stitched first. This is the graft. This is the final whip stitched ITB graft which is done. So now you see there is almost a uniform kind of a graft except this much. So this all goes in the tunnel uniformly. Now coming to the very important part, that is how do we identify the landmark? So basically the landmark is where the distal Kaplan fibers, as sir showed in a very nice diagram there, that where the distal Kaplan fibers of ITB attached to the femur, that is where around that only where our landmark should be. Now we have identified 4 things. That is, the moment you open, first thing which comes on our way is a leash of vessels. That is 3 to 4 small venules which we see, and might be some arteriole which is also pulsating. I'll show you in the video how it looks. Then there is a small area of fat pad which we can see, which is distinct from the other areas. Of course, we can palpate the lateral supracondylar ridge, and the last but not the least, very importantly, the fibular collateral ligament. Now, fibular collateral ligament will become, if we have a doubt, usually that is when we are beginners, even I had a doubt when we were dissecting fibular collateral ligament. Sometimes it doesn't, you can't identify it properly. So what you do usually is you just put it in a figure of 4 position and see how it's becoming taut or not. So the first thing is, these are the leash of vessels. So here you see that, there are 3 or 4 venules which are there. That is just under the graft. Now our point is usually 1.5 centimeter proximal and anterior to the leash of vessels over the lateral epicondyle. So that is our first landmark. Now the second landmark, what we identify is the area of fat pad. As you see, as marked, there is a small area of fat pad which is distinct from the other areas. So this is around, the landmark will be around 1.5 to 2 centimeter proximal and posterior to the fat pad area. Now, you coming to the lateral supracondylar ridge, it's very easily palpable. If you use your thumb and you see the, you feel for the lateral supracondylar ridge, you'll feel a little bit of a ridge kind of a feeling. So that is now 2 centimeter proximal and 1 centimeter posterior to your lateral epicondyle. Last but not the least, we mark out the FCL attachment. And here you can easily, nicely see this is the lateral epicondyle here. This will be your FCL attachment here, and this is going to the head of the fibula like this. These are the 2 small rents we have created around the FCL attachment, which I'll be coming back to it later. Okay, so now this attachment is 8 mm proximal and 4 mm posterior to the femoral attachment of your fibulocollateral ligament. So usually this landmark will coincide with all these points. So once we have identified the landmark, then we go ahead and just use an electrocautery or something and place a bead pin. This is a bead pin placement. You can see vessels still visible here. Now we used a 2.4 mm guide pin. You can see the direction of the pin here, which will be cephalad and proximally. And this is very important while we are drilling for the LET tunnel, especially when you have ACL tunnel there. Now you can also see that we have put an arthroscope through the anterior medial portal to see the, the ACL tunnel, so that we are not, violating the tunnel. So now this is where it comes to the tunnel. Now if say in scenario A, that is, the LET tunnel just violates above or just below the ACL tunnel, we still go ahead and do it because it doesn't really matter here. But by chance, which is there in scenario B, if the LET tunnel is right in the middle of the ACL tunnel, we'll have to, either redo the tunnel of LET or just use the other, fixation devices like staples or something, as told in his talk. Now, this is an example of an eccentric violation, which is acceptable here because it is above the LET, above the ACL tunnel, and it will not hinder our screw placement or your endo button of the ACL. This I am talking about as a soft tissue graft. Now, this is a problematic thing because this is right in the center of the LET tunnel. In fact, in this, I remember this case, we have put a staple for our LET fixation. Now, very important is to create small rents, but good amount of space for the graft to pass under the FCL. Now, it is very important to, prevent any bunching or crumpling of the graft, and there should be adequate space, which will make sure with our mixture forceps or your Spencer Wells artery forceps, we dilate the part under the FCL so that the graft is easily going through, because if this graft crumples or bunches, the whole idea of LET is failed. It won't be biomechanically stable. Now, next thing is before passing the graft, we pass the Nitinol wire. Okay, because after passing the graft, again, screw positioning, it's going to be a, screw insertion is going to be an issue if we don't pass Nitinol wire. this Netlon wire is kept like this. We do the ACL reconstruction after this, and then eventually we go for a screw insertion. So the LET screw is inserted after we have finished our ACL procedure. We have done the screw insertion on our tibial side, and we have fixed the ACL graft. We usually use a 7 into 25 mm screw, which is bio screw. And very, very important is the knee is kept in 30-degree flexion and tibia in neutral rotation. So you have to have one assistant who is, holding the ankle and keeping the knee in a neutral rotation while doing all this. This is of utmost importance, so that the biomechanical advantage of LET is, well, okay. So next we go to pearls and pitfalls of this procedure. Very briefly, I'll go through all the things. I think somebody, sir asked that is the decision pre-operative? Yes, for us at St. John's, whatever LETs were done were all pre-operative decisions based on the pivot shift and also patient-specific requirements. Say a patient is a sports person. Patient has, he's playing a pivot specific sport like a kabaddi or football or something. We don't hesitate to add LET in such patients, because we have seen they are given better results. Okay. And then again, I told you, we have to ensure proper surface marking of lateral epicondyle, fibula head, Gerdy's tubercle and FCL before marking our skin incision. Prepare your ACL reconstruction femoral tunnel before LET. Of course, we have to do that, and we are always visualizing that tunnel while we are drilling the LET tunnel as well. The width of the harvested graft ITB should be minimum of 1 centimeter. In fact, I would suggest that, if somebody is doing somebody is a beginner who is doing LET, can always take a 1.2 or 1.3 centimeter graft, so that you get enough width of the graft to enter the tunnel. Then underlying attachment of ITB, that is vastus lateralis and fat pad, must be cleared of the graft. 4 landmarks again. First is Leishoff vessels, what I showed you, fat pad, supracondylar ridge, and the lateral epicondyle where your FCL attaches. Final point of fixation is marked with the electrocautery, and we clear it of any soft tissue. The guide pin points cephalad and proximally, as I told you, 20 to 30 degrees. We always visualize ACL tunnel through our anteromedial portal while doing the LET, and we see if there is any violation of the tunnel. If the technique and the landmark is proper, very rarely we see any violation of tunnel actually. So always avoid crumpling or bunching of the graft, and always dilate the the path where the graft is going to go, because that matters a lot. It's a very small step, but it matters a lot. Then clear the mouth of the tunnel. We use basket punch to clear the mouth of the tunnel, and of course the surrounding soft tissues. Always pass the Nitinol wire before passing the graft. Ensure proper position of the lower limb while fixation of bio screw. That is your 30-degree flexion with tibia and neutral rotation. Pitfalls, of course, again, I reiterate that crumpling or bunching of graft should not be there. If it is there, please use your artery forceps, increase the passage, and then do it again. Then if there is inadequate visualization of ACL tunnel due to any bony bleed or failure to identify the violation of tunnel, that is, identification of violation is very, very important here. Then again, as sir asked, how do we tension? We just hold the one assistant who is standing on the medial side, just holds the graft, doesn't put any tension. We put a probe under the graft, as sir told, and then we put the screw. Last but not the least, this I think very few people talk about, how the ITB is closed after your graft is taken. Now the remaining part of ITB, you have to be very sure that you suture it very loosely. So what we do is we just suture it with Vicryl. Okay, number 1 Vicryl, just uninterrupted sutures, 4 or 5 interrupted sutures, because this tight closure of ITB then it causes some amount of abnormal patellar tracking. So we have to be very careful not to, do continuous suture and tightly close the ITB. Okay, so now I'll go to a video which I'll just show you how we do it. So this is the skin incision part. We have Gerdy's tubercle, fibula head, lateral epicondyle marked here. Skin incision is around 7 to 8 centimeters here. So for demonstration purposes, we are using this big skin incision. You can always use a smaller skin incision as you become more experienced with this procedure. Minimum of 10 into 1 centimeters of ITB graft, and of course clear the graft off under surface of the graft. Identify the landmarks. Lateral supracondylar ridge is there as a one landmark, then fat pad. This is preparation of the graft with your loop suture. As I told you, this is the final graft. Looks very nice. Then next is again identify this leash of vessels. This, see, now we can easily see there is a filling of these vessels. This is what I wanted to show you in the video. Now this is the FCL attachment. Create two rents, mark those two rents, and then create those two rents. Mark the bead pin placement. Make sure the position of the bead pin is proper. Now see the bead pin placement. This is around 20 degrees cephalad and proximally, and there is scope in the anterior medial portal, and we are visualizing if there is any violation of the tunnel. Again, violation of the tunnel A and B. If I revise, A is okay, B we have to redo or use some other device. This is okay. This is little eccentric violation, which is okay, and we went ahead with the screw placement. Very important. Use a passing suture to see this graft should pass very easily like this. It should not be very constrained. If there is any constraint, use a forceps, increase the passage of the graft, shuttle the graft into the tunnel, exit it through the medial femoral cortex, pass the knit before. So needle wire has to be passed before the graft enters. That is very important. Now the limb is in 30-degree flexion, neutral rotation, bioscrew insertion is done. 6 into 25 or 7 into 25 mm bioscrew insertion is done. So that's it from my side. If there are any questions, you are welcome.
Thank you, Dr. Abhay. It was a wonderful demonstration. It was nice to see new anatomical landmarks being discussed, such as the leash of vessels.
Yes, sir.
Frankly speaking, I had never seen such a wonderful demonstration. Thank you for that.
So I'll urge everybody to. So we are publishing the paper. I think it's free to view on arthroscopy techniques. It should be up and running soon, and I think everybody should read it, and it will be easier for them to, do the procedure.
Thank you.
Yeah.
I think we have already shared the paper in the arthroscopy groups.
Study groups, yeah.
The study groups, and I think people have got access because it is already online now.
Yeah.
And it's in open access journal, so I think they should have a copy of it, and then probably it might help them in their practice. Yeah.
Yes.
While doing LET, if I have to add, I am sure the way you prepare the graft and the way you shuttle it under are very, very important. It is also important to find your landmarks, as you rightly put it. But also you should know that there is a flat area behind the lateral epicondyle which you need to clear with your periosteal elevator before you mark your anatomical position for your LET tunnel. So once you get into that flat area, that is when you can drill your tunnel confidently after marking with the pottery. And you rightly said that you need to pass the inclinal wire before you pass the graft, and also you need to visualize it from the anteromedial portal if you think you are a beginner. Once you are experienced, I am sure you can drill blindly, but sometimes too much of an overconfidence can land you in trouble, wherein you rightly showed that your tunnel had violated in the center and you had to revise it. Imagine you have not put your scope in the tunnel and then you continue to struggle, fixing your graft there. It would not have been a possible thing for you. And I'm sure that was a nice image that you showed for the benefit of the audience.
Very rightly, sir.
Sir, can we, alter the flexion of a little bit to, if we are already decided that we are going to do an LET, then probably can we alter the flexion of the knee while doing the femoral tunnel to, I mean, ensure that the graft doesn't, I mean, tunnel violation is not there, or it's
Sir,
not
if we so if we are doing it in 30 degrees and our beat pin is say cephalad and proximally, usually you will never violate the tunnel if the landmark is proper. So once you find that proper landmark, we have not seen violation. That is only one of where we saw one violation, and I don't think it should be an issue if we keep it in 30-degree flexion also. Of course, ACL tunnel you can't change. That is, standard tunnel. LET, if you have violation, I'd still prefer to go for a staple fixation or something and come off. Doing another tunnel again. If your landmark is not proper, yes, you have to revise it. If you think your landmark is proper and you have already drilled your ACL tunnel, it's better to just fix it with a staple. And I don't think that should be much of an issue. It doesn't have much of a biomechanical disadvantage, rather, putting a screw or a staple. Of course, screw is better, biomechanically much better. So many studies are done for screw versus other fixation devices also. Screw is a little better, but then of course, if you are violating the tunnel, even staple should do.
There are papers saying that when you use staples, especially to fix when you're doing your ACL, the tip of a staple is found to violate the ACL tunnel.
ACL tunnel, yeah.
So papers are coming out like that. So if given a choice, I would prefer to use either an anchor or a screw.
Yeah.
Or if you think still patient is to be treated economically, you can overlap the LET graft on the lateral, fibular collateral ligament, and then suture it
back to its original stuff. Yeah.
that will give some amount of restraint on the lateral side. So that is good enough, because it's kind of a chakrin that you want, rather than doing it too tightly, as Sunit expressed his concern of the compartmental pressure that increases if you tighten it too much.
Thank you. So I think we have discussed almost all the aspects of lateral extraarticular tenodesis, and we have seen a few wonderful techniques and tips from the experts in the field. I would really thank Dr. Rajkumar Amravati sir, Dr. Mevin, and Dr. Abhay for sharing their views and their techniques and making this a wonderful webinar and a very informative one for all of us. We are taking home a few new tricks and information. Thank you very much, sir.
Thank you,
Rajiv, you
sir.
want to mention anything?
Thank you, sir.
Sir, on behalf of Indian Arthroscopy Society, I would like to thank Dr. Rajkumar Amravati for arranging this webinar on such a short notice. I am really thankful to you, sir.
Thank you, sir. Thank you,
For
sir.
honoring the request and giving a good insight about LET, and Dr. Mevin, who presented good functional outcome about the LET and also the analysis of Otto knee device. And Dr. Abhay gave a good insight about technical tips, pearls, and pitfalls about this innovative technique. I'm sure everyone would have loved this webinar. And I'm thankful to my EC colleagues, Dr. Sagar Kakatkar and Dr. Sunit Hazra sir, for agreeing to be the moderator of this session and making this very interactive. And special thanks to my colleague, friend, Dr. Rajiv Raman, who is the joint secretary, and our web coordinators, Dr. Naresh Gaud and Tirth Vyas, and all the viewers. Thank you very much, sir. Naresh, I request you to please stop the live streaming.
Thank
I
you,
think
sir.
the number of viewers are only going to increase, sir. This is really an eye-opener.